about quite a bit today. I'm going to start off with a health insurance joke for you though first. All right, so picture this. It's a rural community. One doctor kind of serves all the community needs. A woman brings her very obviously dead duck into the office, sets the duck on the table and says, "Doctor, please, can you help me?" He looks at the duck and says, "Ma'am, the duck is dead." And she said, "Well, won't you please at least try?" So he agrees. He walks to the back door, opens it, in walks the cat, walks around the table sniffing the whole way, looks up at the doctor, shakes his head, and walks out. A dog comes in, walks around, pretty much does the same sniff test, walks around the table, looks at the doctor, shakes his head again. The doctor looks at the woman and says, "I'm sorry, really, the duck is dead, there's nothing further we can do." She leaves with the duck. A month later, she comes into his office and says, "Are you kidding me? I got a bill for $1,000. You charged me $1,000 to tell me the duck was dead?" He said, "My office visit was only $60, the rest was the cat scan and the lab test." That's about the funniest thing I had to tell you today. So a couple things that I have in front of you. Today, because we have an hour, I have spent hours with groups talking about different provisions of the legislation, and there are certain provisions that alone have taken an hour to an hour and a half discussion. So we're really going to center on some of the things that I think are most important for you to know, and then we'll talk about some things that you really need to know in more depth if it affects your group. So again, the things that we'll talk about today are going to be very brief overviews. And if there's something that rings out that's not familiar with you, either take a note and we can talk about those during the question and answer session. And I will also stick around after the presentation for a while if you have individual questions you'd like to ask. The sheet in front of you is something that we put together at Cornerstone that we have provided to our brokers, and it's a very basic view of some of the things that we think as an employer you need to start looking at, whether it's something that affects your group or something that you really need to start looking at a procedure within your group to make sure you're in compliance with the legislation. So as you go through the checklist, anything with an open box is something that we think you should take a look at to see, number one, does it apply to your size group? And then if it does, that you have a procedure in place to handle that. The other ones with a closed checkbox, those are really items that you really should be aware of. They might affect your rates in some way or the way that you will purchase services going forward and the cost for those. So hopefully you find this helpful, and we'll talk about some of those today. I just wanted to start you out with a few definitions that, as with everything in the insurance world, we love our acronyms. So I just wanted to describe some of those in case I slip and start using them. PPACA, or PPACA, the Patient Protection and Affordable Care Act, was the official name of the legislation as it passed in 2010. I know a ton of people call it a lot of different names, some of them we can't repeat. But I'm going to either call it the Affordable Care Act or the Health Care Reform throughout the presentation. Grandfathering is a term that you would need to know because there are certain provisions within the law that say they don't apply to grandfathered groups. And grandfathering is a concept that says if you have kept your plan in place that was in place as the signing of the bill, March 23rd of 2010, you were allowed to make very minimal changes. If you have kept within those guidelines, your group is considered grandfathered, and there's some things that you would not have to put in place. So anywhere in the legislation that says does not apply to grandfathered groups, that would not apply to that specific benefit. It's our estimation really that the majority of the groups have either lost their grandfathering or will lose it before we head into the 2014 effective dates. HHS is the Department of Health and Human Services, and they are the division that is writing the majority of the rules for health care reform. So again, if I go back to HHS, they are the ones that are releasing the guidelines that we're reviewing. The law was put into place, signed into effect on March 23rd of 2010. There were several things that happened immediately and some things that trailed in the last few years. Where we're really going to concentrate is on the things that started in this past summer and moving forward through 2014. The expected benefits, we tell everyone that there are some things about the healthcare reform bill, whether you're pleased with how it turned out or not, there are some things that will have some great benefits for some members. If you're in the insurance industry and you've known of anybody that you've tried to get insurance for that couldn't because of a medical condition, it is one of the truly greatest parts of the healthcare reform bill. There are some people that truly could not get coverage because of their pre-existing conditions. So that first bullet, expansion of access to benefits, will really be a welcome relief to some people who want to be able to purchase the insurance and just cannot today. The second bullet is something that all of us in the industry are very concerned about. As we pour through the legislation and get through some of these items, there's really nothing in this bill that is going to reduce costs, and quite frankly, there are several that have the potential to increase our rates significantly. And we'll talk about that as we go through the presentation. Denials of care, again, that's something that going forward, if somebody had a pre-existing condition, they won't be told that they can't have services provided because of that pre-existing condition. So again, that's a good thing. The state or federal-based exchanges, that we're going to spend a little bit of time on it, but basically it's you can see it as a marketplace for insurance. The majority of it is going to be built online, but there will be consumer hotlines helping members choose benefits based on a standard level of coverage. I want to bring this to your attention just because we do have some questions about it that come up here and there, and then also there's some changes in how this will work as we head into 2014. We're not going to spend nearly enough time that we would need to go through the whole thing, but it talks about the tax benefits for small employers, and it really was put into place to try to encourage small employers to add these employer benefits for their employees. So what it did was look at a group that's under 25 employees with average wages of less than $50,000. Then the amount of the credits staggered from there. So if you were a smaller group and your wages were lesser than $50,000, you might see the full benefit of that tax credit. And it could have gone all the way up to 35% of your employer cost through 2013. In 2014, we'll talk about how that will change. If you are in this group size category and you have not taken a look at the tax credit, then I would ask you to talk to your accountant, and luckily enough, if you don't have one, we have someone here that can talk to you about that. The expanded coverage for women's health services, again, I'm going to talk about things that we find are impacting the rates, and anytime you add benefits, no matter how good they sound, they're going to add to the cost of the rate of insurance. And this was one piece of it, and it started with any groups who were either renewing their coverage or brand new with a carrier as of August 1st and after. And as those renewals are coming up and as you're purchasing new coverage with a new carrier, these women's services covered under preventive care at 100% will start adding to the plan. The most notable is the contraceptive care. All of these services were included in that women's health bill. There's one thing that I'd like to point out to employers is the piece that talks about the breastfeeding support, supplies, and counseling. According to the legislation, no matter your group size, you should be providing a space within your employment for someone who is breastfeeding. And it talks about the fact that it basically cannot be a closet or a bathroom, etc. There are waivers if you can show that your group size, the expense would be too much for your group, but it is required of all groups, so just so you're aware of that. The summary of benefits and material modification, that piece particularly is one that will draw penalties. So if you have not set a procedure in your employer as to how these will be delivered and making sure you're in compliance, I would strongly recommend that you spend some time to do that. In the first year, they're saying that there won't be any fines levied, but in 2014, those fines will start, and I will explain how this works. Basically, the summary of benefits and coverage, which I'm going to shorten down to SBC, is a very specific summary that was drafted by the Department of Health and Human Services that is to be used by all carriers. In the group market, it is the health insurer's responsibility to create the document, but ultimately it is the employer's responsibility to get that out to your individual members. Most of the carriers, I'm telling you, most of the carriers are doing this for you, but particularly Anthem, if you are with Anthem, they are only providing the document to you and you will provide it to your members. And there are some specific guidelines about how those are to be delivered. This specific provision, regardless of the size of your group, how you're funded, fully insured or self-insured, grandfathered or not, everyone has to provide this summary of benefits and coverage to your members. At the bottom where it talks about ASO plans or self-insured, technically it is your responsibility to create the document, but most of the carriers are helping you do that. The summary is to be up to 4 pages front and back, and you are allowed to deliver it electronically. It follows very strict ERISA guidelines about how that electronic delivery is to be done. And basically, you're making sure everyone has access, and if someone asks for a paper copy, you're ready to give that to them. If you have a summary of plan descriptions, it can be included in that summary, but it has to be right behind the table of contents, and you cannot make any changes to it. So this document is a set format. Whether you're a carrier or a group, you cannot make changes to that summary format. It has to stay exactly the same. As far as delivery requirements and how you get those out, if your group is renewing automatically, I would say the majority of groups with employees less than 50, so if you have 2 to 50 employees, most of your renewals are considered automated. They send you the renewal, you pay the bill, you don't really have to sign any documents. If that's the case, you should be getting those out to your members 30 days prior to the renewal. And again, our recommendation is as soon as you receive that renewal from the carrier, they're going to give you instructions on how to access that. Make sure it goes out right away. If you have an open enrollment period, so a January effective date, and you decide that October is when you start your open enrollment, that 30 days goes away and it has to be delivered by the first day of that your open enrollment starts, no later than that date. When it talks about your contract not having been renewed, they're talking about a benefit change. So if you're making a benefit change, then that has to be provided, that summary of benefits has to be provided within 7 days of the confirmation. Our recommendation is as soon as you sign off the paperwork to make a benefit change, ask for the summary of benefits and coverage and send that out to your members. So in that circumstance, the majority of our groups make benefit changes at renewal. So you are going to be in a situation most likely that you're going to send out 2 benefit summaries every year. We know that's confusing, so any way that you can differentiate between the two, maybe the first one send out with a renewal notice that says this is the benefits based on our renewal. We are still reviewing and could potentially make changes. Then the second one goes out when you actually make the change. For new applicants, new employee, etc., it says within 7 days of their application. We just recommend make it part of your new hire packet and that you've met that guideline. Special enrollments, this would be the birth of a child, a marriage date, anything like that would prompt a new summary to go out. And it says within 90 days, we just recommend as soon as you get that application to add the child or the new spouse, give them the summary benefits at that time. This piece, the material modification, we think will impact smaller groups the most, but there is a potential that it could affect large groups as well. But it says that if you want to make a change outside of your renewal cycle, you must give 60 days notice to your employees before that change can be made. And as someone who's in the industry, it happens all the time. Somebody renews on January and decides in March or April they can't afford that premium. There's some issues with financing with the business, and they decide to make a benefit change. Going forward, you cannot make that change unless you've given 6 days notice to your employees that that is being done. Then I want you to note the fines particularly because not only is there a fine from the legislation itself, which says $1,000 per enrollee. So you have a group of 20 and you decide to change the benefits without notifying them within 60 days, that would be a $20,000 fine for you for making that change. Not only do you have that fine, but the Department of Labor can also come in and fine $100 per person per day that you've not provided that notice. So the fines, we've modeled them out for some larger groups, are huge. So we're asking of all the things, this one particularly, to get you into trouble very quickly. So make sure if your carrier's not providing those out to your members, that you are making sure those are done. Again, the 60-day notice does not apply to your renewal. So if your renewal is January and you make a benefit change on January, then it's either the 30 days prior, or if you have an open enrollment that's earlier than by the first day of open enrollment. We suggest that you just send out a new summary of benefits. They're saying that you can send out a memo, but I would just be leery of trying to catch all the changes in a memo versus just sending out the revised summary of benefits. We're going to talk about fees and taxes as we go through and the impact on premiums. This is the first one that hit, and it started with renewal dates as of October 1st of this year. And it's called the Comparative Effectiveness Research. You'll hear it called the Patient-Centered Outcome Research Institute Fee, or PCORI. And it basically is a tool that's being set up where research is being done on the cost effectiveness and the safety of different treatments for different conditions. So this will end up being a database that physicians and hospitals can use when treating different conditions. Again, the hope is that more rural territories that might not have access to that type of newest education would have access to this database. To actually pay for this, it's supported by a trust fund, and part of that is coming from fees that are going to the insurance carriers, who have already said those are going right back down into the rates on the fully insured side. So from September 30th until all the way through 2019, this fee will be collected on an annual basis, and it's based on the number of covered lives. So if you have a single person and one family with 5 members, then your fee for that year is $6. So that's going to be spread out over your fees for the first year. It only applies to medical plans, not to dental or vision, any of your ancillary-like coverages. If it's fully insured, fully insured plan, the carrier is building that into your rates. If you are self-insured, you will file a separate tax form and pay for that fee as an employer. The carriers will not pay that fee on the self-insured basis. So make sure that that is something that you're addressing. The fees will stagger out through the year. So for the first year, it's $1 per covered life. The second year, it'll be $2, and then from there forward, it will be that $2, and then inflation will be added to that. Again, it will be collected through 2019. The W-2 reporting has been changing frequently since it was initially passed, but the way that it stands today is that for your 2012 tax forms, the only people that are expected to meet this provision are those who are filing more than 250 W-2s. So we have an attorney on retainer that has looked at several of these types of situations for us this year. Make sure most of the laws affect the number of people you have in your group. This one particularly talks about your filed W-2s. So if you have a lot of turnover in your group, or I'll give you an example that we looked at a couple weeks ago. An employer has 80 people in their group, but because of some local tax laws, they end up filing 2 to 3 W-2s for each of their employees. Because they hit 310 W-2s, they had to meet this legislation. So again, not by group size, but how many W-2s that you actually file. And it's asking that on those W-2s for 2012 that you're reporting the aggregate cost of the coverage for your health insurance. The applicable coverage is defined as anything that you offer on a group health plan that's made available in a pre-tax on a pre-tax basis to your employees. So you are including just the medical premium and any HRA contributions to that amount. And you're putting that entire amount, not just what you're paying, not just what the employee's paying, but the total amount that's due for that benefit. And that's going into a new box on the W-2s. You do not have to put health savings account contributions in there, nor do you have to put anything that's going into a flexible spending account. Some of the things that I talked to somebody earlier, the law is consistently changing, and we have deadlines that keep getting pushed. So some of you may have heard of this employer notification guideline that was to be met by March 1st. That has been pushed off indefinitely. So we'll share more information as that comes out, but it basically said that as an employer, you had to send a notice to all of your employees to tell them of the coming of the exchanges, how they would work, and how they may be eligible for subsidies. None of that has been decided at this point, so obviously there's nothing for you to be able to share with your employees. So our anticipation is that it'll be something similar to the Medicare Part D form that you have to send out, but again, no one has even had a look at a rough draft yet. The tax on medical devices, I just put in there so you're aware that that will affect the cost of medical devices significantly going forward. It's an increase on the taxes on any medical device over $100. So you will see those costs go up significantly this year in those medical devices. As an employer, the Medicare payroll tax also started in 2013. So if you have any wage earners over $200,000, you really need to look at that increased Medicare tax of 0.9% and make sure that that has been added into their calculations. This is a piece particularly that all of us in the industry are working very hard to see if we can get it pushed out altogether. It was supposed to be effective when the legislation was signed, and it was for any group with more than 200 full-time employees, and it said you had to automatically enroll that employee in coverage whether they gave you an application or not. So anybody who's in that employer position, you know it would be impossible to know who they want to cover. If you have two plan designs, what plan do they want to be in? Really a logistic nightmare. So they've pushed this off. It's been pushed every year. They're saying now that there won't be guidance before 2014. And again, our hope is that it gets pulled out altogether because we're just not sure how that would really work. This piece particularly is incredibly complicated, and I have spent upwards of 2 hours with groups talking through the employer mandate and full-time employees and how you offer coverage. So what I'm going to go over today is very brief. If can I see a show of hands of employers larger than 50 employees? Okay, we're going to talk about it enough to get you through this, but I will tell you that if you think you ride a line of being over 50 or not, there's a potential that with the calculations you could be over 50. There's a way that you're counting full-time employees that's different than you've ever done before. It's something that you really need to sit down in 2013 and figure out how you will calculate yourself as a large or small group, and then also how you will provide coverage to your employees who are working more than 30 hours. So again, don't get frustrated as we go through this. It does take a couple times to kind of cement this down. There is the employer mandate penalty, and under the penalty there are actually two pieces of that which could end up triggering the penalty for you, and they're two completely separate portions. So we'll just talk about A and B. The code is, under the IRS code, is 4980H, and then they have it separated by A and B. So A says that you have to offer what's considered minimum essential coverage, or they're calling it MEC, minimum essential coverage, which hasn't been defined yet. So at this point, we think they're saying that as long as it's an employer-sponsored plan, it's going to meet the the guidelines of minimum essential coverage. So if you're offering a plan to your employees, you've met Part A. And again, this is for just 50+ employers. If you do offer coverage, then there's a potential to hit into the penalties under B. And B talks about whether it's affordable to an employee based on two fronts. First, that they're not paying more than 9.5% of their household income in contribution. And number two, that the plan design itself doesn't have them paying more than 40% of what's expected to be claims for them in a given year. So first of all, on the 9.5% of contributions, nobody knows what the household income is as an employer, and I'm not going to give my employer my household income, so there's already the impasse that it's never going to happen. So they've set a safe harbor that says if you've met 9.5% of the employee's W-2 wage, if they're not paying more than that, then you would not be subject to that penalty. The other part, again, talks about what's a minimum value, and there's a calculator being developed that a carrier can take their benefit to and say, based on all the data that we have, this type of plan is expected to pay so much for a benefit in a given year. So what they're saying is the minimum is that plan design that you have in place has to cover about 60% of what's expected to be the claims in a given year. And it's not per person, it's not per group, it's based on a national calculator and average claims, what that plan is designed to hold. So if you've met both of those provisions, your plan meets at least the 60% value, and you're not charging your employees more than 9.5% of their W-2 wages, you would not receive a fine under Part B. In either of those scenarios, whether you don't offer coverage at all, or under B that it's not affordable, the only way that a penalty would be triggered is if one of your employees goes to the exchange and gets a subsidy. Those rules, I actually want to show you something. I spend the majority of my day and a lot of my evenings reading. This is one provision that was just released last week that I'm still getting through. So every week they're sending out a new document similar to this that talks about subsidies and how they're going to work them. So it's not all been decided yet, but an employee making between 100% and 400% of the federal poverty level will have some sort of subsidy in the exchange. If that subsidy that they receive is more than what you're contributing in dollars to the employer plan, there's a chance that employee could go to the subsidy and take that coverage over yours. But as long as you've met all of those provisions, they could not get a subsidy if you've done what you were supposed to on the 9.5% and the 60% coverage. They could go and ask for it, but they wouldn't be allowed to receive that subsidy. If you didn't and they get the subsidy, that's where the penalties come in. So under Part A, again, Part A says you're not offering coverage at all. The minimum essential coverage is equal to $2,000 per employee minus the first 30. So if you have 60 employees and you've decided you're not offering coverage at all, you're subtracting the first 30 and then you're multiplying by 2,000. So it's a $60,000 fine for that year for not offering coverage. We have a lot of employers that are saying, I might just pay that fine and get out of insurance altogether. We ask that you look at a couple things. First of all, obviously the benefit, if you are offering coverage today, you're going to lose your tax credit, the tax credits that you get from offering the coverage. And number two, employee morale, and I don't know if you've kind of seen in the news the beating that Darden Restaurants is taking, and Wendy's over their decision to restructure to get away from offering coverage. The public garage may not be what you're looking for. Each of these are going to be collected on an annual basis, but they're assessed on a monthly basis. So let's say, for example, that for 2 months you don't offer coverage, but the rest of the year you do, you would only be fined for those 2 months, not for the entire year. So they are assessed on a monthly basis, but the payment is due on an annual basis. The affordability clause, again, says that if you haven't met the 9.5%, your employees are paying more more than that, or your plan is less than 60% value. If that's the case, each person that goes to the exchange and gets a subsidy, it's $3,000 times that number of employees. So if you have 3 employees go, $9,000 is your fine. If in any way that $3,000 per person fine exceeds that, like for example, that $60,000 in that first group we talked about, that $60,000 is the cap of what you pay. So you never pay both, and you never pay more than what you did if you didn't offer coverage at all. How's the government going to know this? Reporting, of course. Every year, you're going to be asked to provide reporting on how you offer coverage and the types of employees you have. I'm recommending to employers as we meet with them, if you do not have a mechanism for capturing this information, or you already have it in your systems in some way but don't have it in a reportable file, find a way to get this into a format that you can pull very easily, because it's a lot of information. So they're going to be asking, do you offer minimum coverage? Do you have a waiting period, and what is that for new hires? If you have 2 plan designs, for example, a PPO and an HSA, what's the lowest premium option for in your employees? So for your employees, so if you have the HSA and the PPO, you're going to report those monthly costs for the HSA plan. How much you're paying towards the benefit, the number of full-time employees during each month, their name, address, and social security number, the months that each of them were covered under your plan, and then the magic, any other information that they require. So this is how they will keep track of who's getting subsidies, who should be offered coverage through their employer, etc. Essential benefits is more for the small group division. Today that is defined as 2 to 50. In 2014, the state is still making a decision on how we will define that. The federal law says that by 2016, 1 to 100 is considered small group, but each state up until that time can choose 1 to 50 or 1 to 100. So for purposes of conversation today, we're just going to say 1 to 50 because I think that's where they're leaning. But if Ohio comes out and says small group is 1 to 100, this will also apply to that 51 to 99 group segment. This talks about offering a package of benefits that includes services that you might not have seen in benefits before that have met the following criteria: that they're medically effective, that they're cost effective, and that they're truly a medical service. I don't know if you call it the pleasure of sitting on a Health and Human Services call or not, but I was on a call and I think you would be absolutely amazed at some of the consumer groups and what they want added into the health benefits. I was on a call where a woman spent probably 10 minutes kind of ranting on because radon testing in the home was not going to be covered in this bill under the medical insurance. So they're just getting feedback from all over on what should be in a health insurance plan. The state is actually going to choose the benchmark. They have these options, but I will tell you, I think they're very strongly leaning towards the first one, which is one of the 3 largest small group plans sold in the state. Today, that is an Anthem PPO benefit, and it doesn't say that you have to purchase that Anthem design or that deductible or co-insurance. It just says that Anthem as a company covers these specific benefits already. We're going to use that plan design as a benchmark, and all the other companies have to start adding into the benefits to come up to that benchmark. I'm going to point out a few key things that we're worried about from a rating standpoint. The first one is on the bottom right-hand side, the pediatric services, including oral and vision care. This means that for any child under the age of 19, your medical plan will now cover anything that they have to do with dental outside of orthodontist services. So nothing cosmetic, but if somebody has to go in for a crown, a cap, fillings, whatever the case is, that will now go under the health insurance plan instead of a separate dental plan. And all of these services that you see here can no longer have an annual dollar limit. So under a typical dental plan, you saw maximums of $1,000 or $1,500. in the 2014 world, there can be no maximums. That particularly is giving us great concern on what it's going to do to the medical premiums going forward. From an individual standpoint, if somebody's purchasing coverage on their own, a lot of these things, for example, the maternity, I have no intention of having any more children, so if I wanted to buy a policy today without maternity, I could do that. In tomorrow's world, it's added in no matter if I want it or not. So that individual market is going to see significant increases just on the benefits that they will have to add in 2014. Again, there are no annual dollar limits, and the other one that we are so strongly working on says that you cannot have a deductible over $2,000 for single or $4,000 for family. The majority of our groups are already sitting at $2,500 and higher, so this is a huge concern to us. So not only are you going to see all the other increases that come with the benefits that are adding, but for those groups that are sitting at deductibles higher than this, you would have to move back to this lower deductible at your next renewal. Actuarial value. As with any part of legislation, unfortunately, we think they use way too many familiar or terms that are very alike but very different. So when we talked about the minimum value for large group, just keep in your mind that minimum value only applies to that large group segment. Actuarial value talks about small group. And actuarial value is going to again talk about the fact how much is expected to be paid by that carrier for an expected benefit. However, it's going to, this is how small group benefits, either inside or outside the exchange, must be sold going forward by the carriers. So basically, they are developing a national calculator that a carrier will bring their benefit design to, and they're going to look at deductibles and co-insurance amounts, what's your prescription copay, and they're going to assign a value to it. And it will fall into buckets that are called metallic tiers. You're going to hear quite a bit about this year particularly. Those metallic tiers are the only ways that a carrier can sell a product, whether it's inside an exchange world or outside. It will be sold based on these tiers: bronze, silver, gold, or platinum. And it will be based on how much it is anticipated that that benefit will pay. The reason for this change is that through the exchange, they wanted to be able to have members be able to go online and compare benefits side by side. And so to be able to do that, they would have a member come and say, I want to purchase a silver product, and then all the carriers' products in that specific value would fall out for them to see and compare the pricing. But again, you're going to hear a lot about these terms in the next few months, as that is how small group will be sold going forward. Of all the changes that are coming in, this is the one most concerning for small group, combined with the guarantee issue, and we'll talk about how those will combine to cause some issues. Ohio particularly will be severely impacted by this provision because of the way that our rating structures are set up today. So, for example, the age band says that under the new provisions, you can't have more than 3 age bands. Today, we have anywhere from 15 to 20 age bands. What happens when you have those age bands shrink down to just 3 is that you have today maybe a 26-year-old who's paying a couple $100s for a product, and then someone who's older is probably paying closer to anywhere $1,500, $1,600 for that same product. You bring them together and squeeze them down into those 3 brackets. You have that person who's older who's pretty happy because his rates come down significantly, but with that older age usually comes more medical conditions, etc. The younger person now jumps from 200 to anywhere from 600 to 800 in one renewal period, and that healthy 26-year-old is now making a determination: do I want money for insurance or do I want money for the weekend? So it's very concerning to us in the industry that you're going to lose that younger population, and we desperately need them in to keep the pool of rates healthy. If they drop out, all we're left with is that older, usually unhealthier individual, or one with more medical needs at a lesser premium than what they should be paying. So we're working very hard to try to get that into a staggered in position, so that instead of that 26-year-old seeing a bill go from 200 to 800, that maybe the first year is 300, the next year is 400. Still going to be big increases, but nothing like that huge sticker shock that will come with how they have it set up today. And again, remember, you cannot charge different for a medical condition going forward. So that was, a carrier could charge almost 200% difference in their best rate for someone who was very sick. Again, we talked about the small group being redefined as 1 to 100. By 2016, all groups 1 to 100 will now be considered small group. The 30-hour eligibility requirement is for your new hires. So if you have employees that are working 30 hours a week, they are to be offered coverage as of 2014. This provision has gotten so complicated because it's a very complicated formula on how you determine your part-times, whether they're falling in and out of full-time coverage. So if you have not had a chance to look at this and you have a lot of part-time employees that fluctuate in hours, this is something you really need to sit down and take a look at, because it will be something that you will be expected to provide them coverage after 2014. The 30% incentive cap for wellness programs, I would just ask that you see me afterwards. If you're offering a wellness program today, talk to me afterwards, because there's some changes on how you can offer incentives to your employees going forward. And then this impacts large groups, particularly the 90-day waiting period, as long as you can make an employee wait for coverage going forward. So if you had it set there's a law in Ohio for small groups that says 90 days, but for large groups, we have some groups sitting at 160 days, sometimes 360 days. It cannot be longer than 90 days. The insurer fees are those that you're going to see most significantly over the next few months. You probably have started to see information coming from carriers. You've maybe seen articles in the news about this. These two fees particularly will have a very significant impact on rates outside of any of the other changes that are coming in. There's two that you need to be familiar with. The first one is the insurer fee, and it's basically a fee assessed to the carriers that is based on their net premium of contracts that are written in a state. They're going to use that to pay for the subsidies and the credits that will come to individuals through the insurance exchange. And then, unfortunately, from there, the insurance companies are putting it right back down into the premium rates. The total fees to be collected for the first year are $8 billion from the health insurance carriers, and it will stagger up to $14.38 billion by 2018. And then from there, it will be based on their premium growth in the state each year. It applies to the medical, dental, and vision plans, so all of your plans, if you offer all of these coverages, all of them will be impacted by this fee. And it's not tax deductible. The reason that you'll start hearing it now is that it is on to any plan design that has benefits starting January 14th. So if you have a January or a February renewal, it's going to add a portion of this fee in, because your renewal will go through 2/1 of 2014. So you'll be into that 2014 year. By 2014, or that full year in 2014, you'll see the full impact of the increase for this fee. The transitional reinsurance fee is being set up to help stabilize what we know will happen in the individual market. So today you have many people who cannot get coverage because of a medical condition. Once we have guarantee issue where everyone has to be given coverage, that individual market is going to be flooded with very sick individuals who have not been receiving proper treatment for probably many years. So we know that there are certain carriers who are going to take very heavy losses during that first year with the addition of these new members. So everyone's going to pay into a reinsurance fund that will give money back to whichever carrier suffers the biggest losses under this provision. Whether you're self-insured or fully insured, you will pay into this fund, and it's $25 billion over the next 3 years that will be collected. I thought you would find the slide helpful, and it's in your packet. I'm just going to touch on one piece. This was done by the American Health Insurance Professionals, and it said that through a small employer, the impact on an individual premium just on these two fees alone is $2,500 over the next 10 years, and on a family premium is $6,305 over the next 10 years. So this, again, alone will have a very significant impact on rates. The individual mandate and what you need to know about that. You may have heard in the news that now they're using a term called individual mandate plus. So, in the mandate plus, today they've set the penalties so low, they're saying that everybody has to have coverage. You have to have coverage or you'll pay a fine, but the fine is so low that, again, when we look at that 26-year-old, are you going to pay $600 or $800 a month, or are you going to pay $95 one time and not have to have coverage? And then anytime you want coverage, you can get back into the insurance at any time. So when you have guarantee issue, it sets up that constant negative that somebody can drop off the plan and jump back on whenever they're sick. So the penalty for that has to be high enough to keep somebody from doing the jumping on and off. What the insurance industry has recommended and what they're looking into is, can they do what's called a mandate plus? So not only would you have this $95 fine, but you would also have to pay an increased weighted. If you dropped off coverage and came in only when you're sick, you're going to pay a higher premium than the majority of people. So it's something that they're looking at. On the exchange is basically a shopping, if you can just look at it, that's a marketplace. And in fact, that's how the Department of Health and Human Services is starting to rebrand it as marketplaces. You will have both public marketplaces and private marketplaces. The public exchange can either be set up on a state or a federal level, or they can decide to do it as a partnership. These exchanges need to be ready and operational according to the law by 2014 effective dates. So they have to be open and ready for open enrollment as of October of 2013. It's my own humble opinion that they will not be ready, and if they are ready, really God help us, because there's not enough time to put them together based on, again, this is just talking about the subsidies and how we're going to structure the subsidies under the exchange. We haven't even gotten to the building of the exchange itself and who do you determine is eligible and how do you put them into coverage. So if they're ready and they're saying that they're going to start adding members, we're going to be in big trouble. But I just don't think they'll be ready in time. There's 19, the federal government thought that the majority of states would want to run their own. Well, obviously, because of the complexity and the length of time that it's taking to get rules out, 19 states are the only ones who have said they'll run their own exchange. Everyone else is either saying we'll do a partnership, but you're building it, and a lot of them have said you're running it all together. I don't think they had any idea that they would end up with that many exchanges. So it's going to be a monumental task for them to set up at least 25 exchanges, if not over 35. Although Ohio did not use the language in their letter, we're pretty certain they're leaning towards a partnership, which says the federal government will set up the exchange, and then the state of Ohio and the Department of Insurance will still continue to run like contracts with the carriers and consumer complaints and things of that nature, but the Department of Health and Human Services would actually run the consumer hotline and the actual building and paying of the exchange. You're going to hear the term navigator, and the best way I can describe this is it will most likely be like a union group. A union would apply to be a navigator, and they're giving information out to their membership about how to enroll in coverage, what kind of subsidies they could look at, but they cannot sell a benefit. So you're going to hear the term navigator come up quite a bit, and it's basically an educational position that somebody is going to be getting information out to members about how to enroll in the exchange. For small groups, I actually think this is probably one of the most exciting parts of the exchange concept, whether or not it's going to be ready initially or that it's going to be pushed off. a lot of the private exchanges are jumping very quickly to see how they can get this set up and make it work correctly. But basically, under the SHOP program, a small business for the first couple of years is most likely going to be groups of 1 to 50. But you bring your benefit to the exchange and you say, as an employer, I want to offer coverage. I want to give so much in premium dollars contribution to them. The employees can choose whatever they want. So you can have a group of 6 employees, and each of them could choose between a Medical Mutual, and Anthem, and United, and everybody can take their own coverage, but the employer would get one bill back. Again, it's a very exciting concept, and it gets the employer out of having to make that decision of what benefit will my employees have this year or not have, and never again are you going to hear the complaint of why did you move them there, my doctor's not in the network. They're choosing their own plan design. And again, the best part of that is that you get one single bill. So you're out of the application process. The exchange world is doing all of that, enrolling, education, collecting of all of the information from the different carriers, and you get one bill. Initially, they've set it up so that a state can decide we're going to have an exchange, a SHOP exchange for groups of 1 to 50 or 1 to 100. I will be surprised if they take it up to 100, but they're saying by 2016 you have to have groups of 1 to 100 in that exchange world under the SHOP program, and then by 2017 any size group would have the ability to do that. So even a 100+ group could technically bring their benefit to the exchange and run it through that format. Note at the bottom, when we talked about the tax credits at the very beginning, as of 2014, the only way you can continue as an employer to get that tax credit is if you purchase your coverage through the SHOP portion of the exchange. And then the very last piece I'll leave you with, again, talking about rates and a concern that we have on rates is what's called the Cadillac tax. And this was a piece particularly that the unions were very successful in pushing off until 2018. It was to be effective 2014, but in essence what happened when they pushed it is that it pretty much guaranteed that a lot of our groups are going to get hit with this tax, not just those richer benefits. So it says that if you're paying more than $10,200 for a single premium or $27,500 for a family premium, your benefit is considered a Cadillac plan, and there's a 40% excise tax on that benefit. And the carriers will be paying it, and guess where that's going? Right back down to 2 rates. So again, because they didn't put any trend in there, it didn't talk about the trending of renewals, it didn't talk about inflation, any of those pieces. We anticipate that 50% of our groups are going to hit that Cadillac tax law if they don't change that provision. I know I've thrown a lot at you. Hopefully you've taken notes throughout. Are there questions that I can answer about any of the provisions that you've heard?
Do they have any way of tracking? I've run into many employees over the last 2 years who really know how to work the system. And you have a single mother who works for you for 30 hours a week, and she wants all 5 of her children to be on her medical insurance. Yet she lives with the father of the 5 children who maybe makes $200,000 a year. Where are they ever going to start checking on this, both income tax wise and medical insurance wise? It's killing employers.
Well, there's one piece that has helped employers somewhat, because there was a lot of concern that they were going to make them start covering spouses as well. So they just released regulations a few weeks ago that said that you as an employer have to offer coverage to employees and dependents, but dependents does not include spouses. So, but technically they're not checking to see if it really would be better that they're on the father's plan. But I know there's people that have the spousal carve-out set up, or saying if you have coverage and your dependents to be on that spouse's plan, I would be very careful about what's going forward, because the law is pretty particular about the fact that you have to offer to employees and their dependents. there's one question there. I'm going to be available after, go ahead.
Let me ask one question. In terms of how you're cost sharing now with your employees, or how does that work in terms of deciding if you're going to pay what percentage of this coverage?
Well, again, I shared that there's a safe harbor that you can use, that they can't pay more than 9.5% of their W-2 wages. So a lot of employers are saying, you know, if I have that same hourly wage for the majority of my employees, I'm just going to start taking from their salary 9.5% of their W-2 wage, and that will be my making sure that I don't go over that 9.5. But an employer can choose anything from 1% to 0% to anywhere up to that 9.5%.
Isn't that 9.5% based on single coverage?
It is on single coverage only, correct. You want me to cover that? All right, again, I'll be available if you have individual questions. If I can leave you with some things of thought, the SBCs, again, because they draw a fine, please make sure that you have something set up to make sure you're meeting that provision. There are no fines this year, but as of your renewal in October of next year, of this coming year, that's when the fines will start to attach if you're not meeting that provision. If you are over 50, or if you follow very close to that line of 50 employees, then you need to sit down and look through the calculations that they have of counting what are considered full-time equivalents, which are your part-time employees, to determine whether you are or are not a large group. That's where you'll fall into a category of either having to offer coverage or pay the fine. And then again, if you have employees who are under and over that 30-hour mark over a given year, and you're not sure whether or not you have to offer them coverage, there are a ton of safe harbors set up for how you will calculate those employees out, but you really should get that provision, that procedure in place for your company during this year. And then the last thing is the employer reporting. Start setting up a way that you can gather that information that you will need to start submitting to the government on an annual basis.
How do they know if you're providing the SBC timely, or how are they going to track that?
We're assuming that most of it will be on a complaint basis, so if you have one employee complain that they have not received a summary of benefits, the other concern we have is that they're adding, some of the numbers have been skewed on how many IRS agents, but the IRS is being tasked with auditing for the majority of these fines, and they're saying that once they start the audits, it's going to include everything. So whether you have a summary of plan descriptions in place, whether your COBRA regulations are up to date, all of those types of things. So the IRS agents are the ones that are going to pair with the Department of Labor and start doing those audits. So all it takes is one trigger, and I think you set yourself up for an entire audit of your health benefit.
And who is educating the employees, and who is going to provide any type of protection for the employer, because you have disgruntled employees?
That's why they're saying if you meet the guidelines, if you followed all of the safe harbors and all the laws, and trust me, I know they're overwhelming. That's what John's going to do for you. That's what we're trying to do, is make sure that you're educated about the provisions and try to give you, for example, the checklist, and make sure that you're going through and putting the provisions into place. But again, a lot of it is back on the employer, unfortunately, and I think they've set it out to a place where a lot of employers are just going to throw their hands up and say, we're just not going to do this anymore. So if you are keeping your benefits in place, 2013, in my estimation, is your year of planning to figure out if you'll offer coverage, how you'll offer it, and how you'll stay in compliance with the legislation.
Can employers have things like, say they offer coverage for management but not for other employees, or is it going to be across the board?
Today they can, but there is a discrimination piece that was supposed to be in effect in 2010, and it again keeps getting pushed back because of just the complexity of how they're going to spell it out. But my anticipation is that by 2014 they will have that discrimination piece in place that says you cannot offer different benefits, you cannot charge different rates, You cannot give different HSA contributions or make someone wait different amounts of waiting period based on their class of employment. So salary, hourly, it seems to be that the only thing they're going to allow is union versus non-union.
So are all of these coverages gonna be handled through brokers, for instance, like the insurance, or is there gonna be somewhere else that employees feel that wouldn't be brokered in?
Technically, you can go through the exchange, and what we're trying to tell people is as an employer, there's so much to know about the guidance that you're safest sticking with a broker because they're going to be the ones that are familiar. And we use the example of when the Medicare supplement plans were first released to the market, brokers weren't allowed to sell them. And very quickly, people realized that if the brokers weren't involved, the wrong products were usually sold, members didn't know what they were getting, and there was no place to call for customer service afterwards. You can technically go to the exchange.
Is there a reason why someone would just go for the exchange versus go for the broker? Is the cost gonna be different, or?
The cost will not be different. You cannot, as an insurance company, charge a different rate inside or outside of the exchange. So to me, the premium's already built in for a broker, so I don't know why someone would go separately, but my information is going to be that more tech-savvy person that wants to go online and do everything in the evening, in my estimation.
Barb? Go ahead.
What? Whatever.
Just a quick question, all those fines you were talking about, those are all non-tax deductible.
Correct. All the fines are not tax deductible.
You mentioned too that there were fees that were not tax deductible.
Pardon me?
You said something about there are fees, annual fees, or something that was
They're calling them fees, I call them a penalty, but the fees that are being assessed to the large groups on whether you offer coverage or not offer coverage, those are called fees and they're not tax deductibles. In essence, they're a penalty though. Yes.
Very simple question. If I have less than 50 employees, do I have to have health insurance?
No, if you have less than 50, you do not.
If I have a plan, can I terminate that plan?
Yes, I mean, if you're talking about under 50, yes. And again, even if you're over 50, these calculations are kind of complicated, so I would still recommend that you sit down and talk with John about how that works, but you could technically be someone who's over 50, but when that reduction of 30 comes in, you could actually not have to end up paying a penalty. If you end up with less than 30 full-time employees, you only have to offer coverage to full-time employees. So let's say you're a group of 55 and you get to subtract the first 30. If you have less than 30 full-time employees, there is no fine. So again, it's kind of complicated. Make sure you talk to John about how those calculations will work.
If you are a union employer and you have 80 people out in the field and 10 in the office, how many employees do you have?
They all have to count together today, your union employees, unless they're being paid under a separate fund. But if the employer pays that for that employee, they're on their W-2, then that person is an employee of that company and they're counted towards the full-time or part-time counts. The other thing you have to be aware of is also common ownership. If you have common ownership under the calculations for whether you're a large group or not, everybody's included together for that count.
Seasonal employees are not considered, correct?
Seasonal employees are counted towards this is where it gets into the really complicated stuff, but seasonal employees count towards whether or not you're a large group or not. And of course, there's a seasonal employee exception. So you're going to count each month. So let's say I have 20 full-time employees and then 20 seasonal employees each month, and then 20 part-time employees. Each month, I'm going to say I have 20 full-time, and that includes, I have 40 full-time, that includes my full-time seasonal, and then I'm going to do the calculation for those part-time hours to see what my full-time equivalent is. I'm going to add those two numbers together, and that's my count for that specific month. Every month I'm gonna do that. And if the only reason I bump over 50 when I average that all out is because of a few months of seasonal employment, I can say that I'm not a large group employer just because of those few months. That's gonna help the people who maybe have like an agricultural type of company, or maybe you're a golf course, or a retailer, somebody who has just really heavy employment during a few months. That seasonal employee exception will help them not have to get bumped into the large group category just because of those few months.
Just to follow up on that, on the more complicated side, the variable hour employees, what you're talking about.
Well, a variable hour employee is a formula that you're going to use throughout the year. If you have a lot of variable hour employees, there are calculations that you're going to have to be doing on an ongoing basis to determine if they're eligible for coverage and how you offer them. Super complicated. It's, I read this legislation day in and day out. It took me probably 5 good sessions with our attorney to get this down pat. So it's a very complicated formula.
One more question. If you have a small group, like 12 employees, is it smarter probably not to even carry the insurance and have to worry about, you know, you don't have the resources to make sure you're following all these rules, and it's better just let them go through the exchange?
Well, the question is, a small group employer under 12, are they better to just drop it? I have people all over the board right now. So I have employers that are like, I want to keep offering this benefit. How do I do it, and how can I do it cost effectively? And then I have others who are like waiting until 2014 hits so they can drop the coverage altogether and send them through the exchange. So really, I mean, from the complexity of the compliance, we do have groups that are saying, I can't do it anymore. We have others that are fully immersing themselves into it and hiring somebody who is just going to handle healthcare reform, and they're starting on their process. So we have it kind of all over the board right now.
What about someone who's working as an independent contractor? Are there any circumstances they would have to be considered part-time?
If they're 1099 and you do not have to cover them under your plan, there are carriers that today will let you do that if they're working solely for you, but the healthcare reform law does not change the fact that you don't have to offer them coverage. However, if it's under a temporary agency, of course, there are safe harbors around that. So it talks about when you do and don't have to offer to a temporary employee, and it basically is whoever's holding the W-2 on that employee is the one who offers benefits. So if you have a temporary agency and they're supplying that employee to you, and it's on the temporary agency's W-2, then they're the ones that have to provide coverage, not you as the employer. Yes.
Are there any other unintended or unintended employees?
I'm sorry, I didn't.
Are there any other issues to look out for employees?
Leased employees, it's not been completely finalized yet. They're still in a comment period. This has been probably one of the most frustrating parts about the legislation is previously when any kind of insurance law was passed, you would have what was called the preliminary ruling, and then a comment period, and then you get the final bill. Today we have things that are coming out as a what do you think? We have them coming out as preliminary, we have them coming out as interim final rules. I don't know what an interim final rule means, but so that temporary or leased employee is in the middle of what's called an interim final regulation. So they've got rules written, but there's a comment period that's extended for about another month yet before they make the final rule. So there's more to come on that one. On a lot of these rules that are in the comment period, they are writing legislation today, rules onto these legislative pieces that try to keep an employer from gaming the system. I have every type of employer possible coming to me and saying, what do you think of this? This is how I'm going to do it. And they're trying to close every single loophole that an employer is using to try to get out of getting out of offering coverage to their employees.
Can you talk a little more about the SHOP program?
Yeah, the shop, I'm really truly excited about that, and the concept behind it is complicated. Can I pitch just for a moment on our, we have been in the process of building our own private exchange for over 2 years. So we're so far into the planning now, all we're waiting for is the benefits and the rates to be able to drop in. The federal government has not even started their planning on the exchange. It's so complicated that we're not sure how that shop is gonna be ready. I think the private exchange world will be ready as soon as the benefits are ready to load in. So not only, for example, our own Cornerstone, but I would say there's another good 5 private exchanges that are ready to move on this concept as soon as the benefits are released. So you'll see more on the private exchange world than on the public exchange initially. But if you go to a private exchange, you cannot get the tax credit. So that's the issue we're working through right now. But as an employer under a private world, not only would you get, your employees get the option of choosing any medical plan that they want, but they could also choose whatever ancillary line they wanted. So whether it's, dental, vision, critical illness, cancer policies, long-term care policies, we have contracts with all these carriers that are coming in and are going to be able to sell that through the private world. So again, I think you're going to see it much quicker on the private world than you will the public world, because it's an exciting concept for how to sell benefits going forward.
Will that be coordinated through brokers as well?
Yes, both through the exchange or in the private world, you would still work through a broker. You could go directly. I don't know why a group particularly would go directly to the exchange. I think it's still something the broker's going to guide you through.
You said that like an employer can allocate so many dollars per employee.
It's called defined contribution, and that's when we talk about that minimum essential coverage. This is what we're waiting for legislation to specifically say that a defined contribution is set up through a health reimbursement account, but it's called premium only. So instead of under a health reimbursement type of policy, you're putting money in that says if your expenses go over this amount of money during the year, you can take out of this health reimbursement account. A premium only account says, here's the money we're setting aside for you. You can do whatever you want with it as far as your insurance coverages. So you can take a lesser insurance plan and then more ancillary coverages, or you can take a really rich medical plan and have none of the other additional benefits. If the premium only HRA or that defined contribution model is accepted as minimum essential coverage, I think you're going to see huge development in the private world of getting that set up. So, but that's an open question right now is will they allow it? But you would just say, I'm going to give so much money to my employees every month. I'm going to send it to this exchange world, and then they put it into their computer system, and then the employee goes through and picks benefits until that money is exhausted.
What if the employee doesn't, maybe they don't want or they don't, say you allocate them $5,000 a year, but they only use 3? Do you still have to fund that money in? Does that money just go on there?
You would use it just as any other kind of HRA expense reimbursement then. I mean, most employers aren't going to set up a dollar amount that allows them to not use it, so.
And then are you allowed to have varying degrees of contribution based on the employee, who the employee is, or whether they?
I don't think under that discrimination rule you'll be able to do that, but that has not been completely written yet. I think union versus non-union you'll be able to, but no other class of employees like salary versus hourly.
If you've got a shop where you've got 5 or 10 office employees and you've got 25 or 30 union employees, and the unions have their own health benefit plan via the union, and you set up that exchange with an employer defined contribution, do you have to give the same amounts of both union and non-union defined contribution?
We don't know that today. We think that is going to be allowed, that you'll have separate union versus non-union, but the rules have not been completely written yet. We think that yes, because in essence what the unions were coming back and saying is if you put this discrimination piece in place that you can't offer different benefits, we have the potential as a union to get shoved down back into the regular employee benefits in a group. So they're pushing pretty hard to keep that separate. So I think that it will be passed that way, but I can't say for sure today.
Is there a minimum or maximum for the employer contribution for
as long as it doesn't go that the employee's over 9.5% of their W-2 wage. So most employers would just say, I'm putting this much in, so that I already know based on their W-2 wages, here's what 9.5% is, I'm putting the remainder in.
So then it's gonna differ because depending on how much each employee makes.
Yes,
Okay.
yes, but not by class of employee.
Is this gonna touch BWC in any way and increase rates for employers, or do they correlate, or?
I'm not familiar enough with the workers' comp to be able to answer that. I'm not sure if anybody else is.
Repeat the question.
How, if at all, it will affect the workers' comp premiums, I'm not really sure. And I'm not getting up to speed on that. That's a whole other one on its own.
Barb, they have out-of-pocket amounts on different platinums, gold, and whatever it is now, don't they?
The largest out-of-pocket that you can have on any plan going forward in the small group market will be what is set up today for the HSA plans, which is, that out-of-pocket is pretty large. But based on, if I'm understanding your question, there's two parts of that. The out-of-pocket that the plan design sets up, and then based on where you fall in that 100% up to 400% of the federal poverty level, if you fall down towards that lower end, there's also a cap that says you can't pay more than so much in out-of-pocket expenses either, and they're gonna give basically subsidies on that part as well. So not only on the premium, but also on your co-payments and co-insurance amounts as well.
So what happens to HSA?
As far as HSAs, the current administration does not like HSAs. They've been very clear on that. Everything's being done to try to save them, but if they stick at that $2,000 mark, I think they will basically go away. I know, it's lame. Okay, you won't let that look up, I need a drink, so. I will be available if you want to ask questions individually, and if not, and you think of things over the next coming days, just give those to John and I can answer them from there, but thank you.
Barb, thank you. As I said before, as things evolve, we will be communicating with you on updates. I can't tell you the number of hours that I've spent the last 3 months watching tape webinars that I can't take time out during the day to sit for an hour or two. It is just amazing, and there's different opinions coming out from different carriers. So it's a new world. Welcome. But we'll do our best to keep you informed between now and 2014. And thank you again for attending, your attention, and let's have a drink.
Ours open. Ours open.